Glaucoma is one of the leading causes of irreversible blindness worldwide. It refers to a group of eye disorders that result in progressive damage to the optic nerve. The optic nerve plays a crucial role in vision by transmitting visual information from the eye to the brain, and once it is damaged, the resulting vision loss becomes permanent. Glaucoma is commonly associated with increased intraocular pressure. This occurs when the aqueous humor inside the eye does not drain properly, leading to a gradual buildup of pressure that damages the optic nerve over time. Glaucoma can be broadly classified into two main types. The first one is open-angle glaucoma, which is the most common type. It develops slowly due to impaired aqueous humor drainage, causing a gradual rise in intraocular pressure. Because it is painless and often asymptomatic in the early stages, diagnosis is frequently delayed. Next, angle closure glaucoma, which occurs when the drainage angle becomes suddenly blocked. This leads to a rapid increase in intraocular pressure and may present as an acute eye emergency. What makes glaucoma dangerous is that the vision loss is irreversible and often progresses silently without noticeable symptoms. For this reason, glaucoma is known as a silent killer of vision. Therefore, the objective of this presentation is to provide an overview of glaucoma while highlighting the importance of early detection in preventing irreversible vision loss among citizens.
Next, we will look at the key anatomy and physiology involved in glaucoma. Aqueous humor is produced by the ciliary body, and it is important for maintaining intraocular pressure and for supplying nutrients to the cornea and lens. The aqueous humor then flows from the posterior chamber through the pupil into the anterior chamber, as shown by the arrow in the diagram. From there, it drains through the trabecular meshwork, which acts as a filter to allow aqueous humor to leave the eye. The fluid then passes into skin canal and finally into the bloodstream. This continuous production and drainage of aqueous humor creates intraocular pressure, which is IOP. Normal IOP is between 10 to 21 millimeters, help maintaining the shape of the eye, support the optic nerve, and keep fluid balance stable. The optic nerve, as shown at the back of the eye, carries visual information from the retina to the brain. When the trabecular meshwork does not drain aqueous humor efficiently, intraocular pressure increases. The high pressure compresses the optic nerve, leading to optic nerve damage and eventually vision loss, which is glaucoma.
Next, the main pathology of glaucoma involves an increase in intraocular pressure, which occurs primarily due to impaired aqueous humor outflow rather than excessive production. Normally, aqueous humor is produced by the ciliary body and drains through the trabecular meshwork. In glaucoma, when the outflow through the trabecular meshwork is impaired, aqueous humor begins to accumulate within the eye. The accumulation leads to gradual or sudden increase in intraocular pressure. Now that we understand how IOP increases, let's look at how it damages the optic nerve. In glaucoma, damage to the optic nerve occurs through two main mechanisms: mechanical and vascular, also known as ischemic mechanism. First, the mechanical mechanism is mainly related to increased intraocular pressure. When IOP rises, it compresses the lamina cribosa, which is the structure where optic nerve fibers exit the eye. This compression disturbs axonal transport, meaning nutrient and signal cannot travel properly along the nerve fibers. Over time, this leads to retinal ganglion cell death. The second mechanism is the vascular or ischemic mechanism. Increased IOP can reduce blood flow to the optic nerve head, causing reduced perfusion. Chronic ischemia then results in oxidative stress, which triggers apoptosis or programmed cell death of optic nerve cell. In open-angle glaucoma, the anterior chamber angle is open but the trabecular meshwork is dysfunctional, causing a gradual increase in IOP and chronic asymptomatic progression. In angle closure glaucoma, the angle is narrow or close due to iris blockage, leading to a sudden rise in IOP and acute asymptomatic presentation.
Symptoms and complications of glaucoma. Open-angle glaucoma. No noticeable symptoms at first. Vision loss begins slowly. Patchy blind spot in periphery. For acute angle closure glaucoma, sudden onset of eye pain, headache, nausea and vomiting, red eyes, reduced vision, hazy cornea, mild dilated pupil, and high IOP. For complication is progressive vision loss, permanent blindness, central vision loss, blind painful eye, corneal damage, optic nerve atrophy, and retinal detachment.
As discussed earlier, glaucoma develops through complex pathological changes that ultimately damage the optic nerve. However, not everyone has the same likelihood of developing this condition. Therefore, understanding the risk factor is important for early prevention of disease progression. In this section, I will discuss 4 risk factors associated with glaucoma. People who have a family history of glaucoma are at a much higher risk of developing it. This may be due to gene mutation that affect the way the eye regulates pressure, or they inherit changes in the way their eyes are structured. Moreover, injury to the eye can lead to secondary open-angle glaucoma, which may develop immediately after the injury or several years later. Both blunt trauma and penetrating injuries can damage the trabecular meshwork and impair aqueous humor drainage, resulting in traumatic glaucoma. In addition, glaucoma is more common in older adults and is one of the leading causes of blindness in people over 60. The trabecular meshwork, which drain aqueous humor, become less efficient with age. This can lead to gradual elevation of intraocular pressure. Lastly, treatments for other conditions may increase your risk of glaucoma. For instance, prolonged steroid use has been linked to an increased risk of primary open-angle glaucoma.
Now, I will explain about the treatment for glaucoma. The primary objective of all this treatment is to lower the intraocular pressure to prevent damage to the optic nerve. We typically start with eye drops or oral medicines. Depending on the patient needs, we may prescribe more than one type. As example, we have prostaglandin. These eye drops works by increasing the outflow of fluid from the eye. Then we have beta blockers. These help lower pressure by reducing the actual production of fluid. And then we also have alpha adrenergic agonists. These are dual action. They reduce fluid production while also increasing its outflow. Then we move to the laser treatment. If medication isn't enough, laser trabeculoplasty is an effective option to enhance fluid drainage. There are 2 types. First is argon laser trabeculoplasty. This uses a high energy laser. However, because it can impact the tissue, it is not a repeatable treatment. Second, we have selective laser trabeculoplasty. This is a more modern approach using low energy light. It stimulates the eye natural drainage system without damaging surrounding tissue, which makes it replaceable if necessary. For more advanced cases or when other methods fail, we turn to surgery. We have trabeculectomy. This is a filtration surgery where we create a new drainage opening in the sclera. This allows fluid to bypass the clogged natural system entirely. Second, we have MIGS, minimally invasive glaucoma surgery. This procedure uses microscopic device to create new pathway for fluid. MIGS is often combined with cataract surgery and is ideal for mild to moderate glaucoma. Lastly, we have glaucoma drainage device operations, GDD, for complex cases. Devices like the Ahmad valve or Barber shunt are used. A tiny silicone tube is placed under the eye surface to drain excess fluid and protect the optic nerve.